Hello, everyone. I'm sure there'll be more joining, but I'm just going to give a little introduction. So my name is Tiffany Grunwald. I am the Executive Director of the Women's Health and Wellness Institute, and this is our first patient education seminar. So we've been working through a few kinks in our IT. It's when you need a 13-year-old around to help you do that. But we have a few other really smart people. I think you might be the youngest person in the room that helped us do that. Anyway, we have a great topic tonight, which is understanding hereditary cancers and prevention. You know, I think breast cancer is kind of the one that we think of, but there are so many other things that we are learning and knowing. And, you know, even in breast cancer, you know, we knew one thing 15 years ago, and now there's 27 traits we can look at. And so we have two brilliant people with us tonight from our Cancer Institute. We have Molly Frankle. Come stand up, Molly. So Molly's a senior genetic counselor. So if you had questions and filled out a questionnaire and you're like, oh, maybe I should figure out if I need to get testing or what my risks are, you would meet with someone like Molly and delve into that a little bit more and see which specialists you should see, what other people you should see. So we're super happy to have Molly here. She's been with St. John's since 21. Mm-hmm. Okay. Yep. And so we're happy to have her here, and even, well, I'm not going to say happier, but
no, it's
but
okay.
we do have the amazing Ora Gordon with us, who is a physician. She's the executive medical director of the Cancer Institute, both the Disney Cancer Institute and the St. John's Cancer Institute, and is a specialist in genetics. She's a wealth of knowledge. I've learned so much from her over the years. So, you know, the format is, and some of you have been on a few of our Zooms like this, we're going to give some information and then turn it over to questions. So you can either put those in the chat, you can raise your hand. I'm going to be off screen kind of monitoring the Zoom chat, but Dr. Gordon has some great slides and Molly's here to back her up. And we'll get going from there. So Dr. Gordon, thank you for being here. I know you had meetings all the way up until just 6 o'clock.
Absolutely, such a pleasure, and just to echo that, you know, so glad to see everybody. I don't know, are there folks in person, or is
yes, we do have people in person.
To be super interactive, and you know, this sort of a test drive on kind of the hybrid model, and Molly is there. So what I would like you to just stop at any point that you want to ask a question. I would say probably just, you know, raise the hand on your screen, put something into the chat or to the Q&A or to the chat, and then Molly can take pause in the room and just say, hey, we got a question here. Okay, so the theme for tonight is, you know, understanding hereditary cancer, but it's really about precision health and precision prevention. And because we are on the cusp of Breast Cancer Awareness Month, that use a lot of breast cancer susceptibility to frame how we take each patient and sort of say, this is your individual risk. This is individually how we want to manage you going forward, or here is how we can individually define that you are not at risk, despite maybe having been told for many decades that you are because of your family history or because of your nodules in your breast and whatnot.
Or can I just stop you for 1 second? Because precision medicine is a term that's become much more common in the last 3 to 5 years, but I feel like a lot of people don't know what it is. If you were to ask anyone, they'd be like, of course I want precision medicine. That's the only thing I want. But can you just explain what that term actually means?
Yeah, and I think it means different things in different contexts. So when I use that word, or when we use that word, when we're thinking about risk and prevention and wellness, it's really saying, how can we individually separate you from the big numbers? Say, okay, when we hear things like 1 in 8 women in America are at risk for breast cancer. Well, what does that mean to you as an individual? What does that mean right now? What does that mean over the course of your lifetime? What is your risk based on your personal risk factors, your family history, your genetics? And we tie that all together. And then we come up with a refined ability to take care of you for breast cancer, for any other cancer susceptibility, for your cardiovascular risk. So this is really the way we're trying to say in all areas of medicine, how do we take the opportunity to take everything that we've learned from big data and really make it about the one person in front of you at that time to better say, this is what you need based on all of this input and information we have. We use a lot of words for precision therapy. So people who have had cancer, who have other diseases, who have autoimmune diseases, and we target the disease with a specific medication that is designed or to be responsive specifically to that tumor or to the features of that autoimmune or that cardiovascular risk for coronary artery disease. So we use precision therapies in that terminology. But in this sense, I'm really talking about saying, how do we separate you from the masses in understanding risk and understanding how to best care for you? So once again, just Molly will stop me or you flag up when you have a question. So there are a few things that, have really evolved. And like Dr. Grunwald said, that, what has changed in the last 10 years, it's just an incredibly rapidly moving space when it comes to hereditary cancer and understanding the genetic vulnerability to cancers in particular. And now the more we learn, it's really the genetic susceptibility to all adult diseases. That big blue part of the pie that we see, that you say is sporadic, is just going to keep getting smaller and smaller as we understand and define both the single genes, which we'll talk about, and the genomic risk, meaning how is the totality of your genetic information helping to protect you or put you at an elevated risk. Back in the day, this red wedge of pie used to be about 5%, we would say 5% of breast cancer and other cancers are hereditary, meaning due to a single gene like a BRCA mutation. That just keeps going up. The more we look, the more we understand, the better the technology is, the more we find that almost all solid tumors have somewhere between 10 and 15% being a single genetic susceptibility, putting that person at risk. Doesn't mean they're going to get cancer, but it puts them at elevated risk. And so this has changed so much the landscape of who should have testing, coverage for genetic testing, and how we decide who and when. This 20% familial will get to the back half of the talk, which is really understanding these tiny variations in your genetic information that makes you perhaps more vulnerable or more protected, where we see multiple people in the same family who have a cancer like breast cancer, but we can't find a single genetic change. So this has been an area of great activity over the last 10 years or so, and really starting to make a difference in us being able to understand one person's risk compared to another's. So this looks very scary and busy. I'm going to actually read it to you from right to left, just to help explain it. And then just for a little bit of, do you guys see my cursor?
Yes.
Okay. So this is the genetic biopsy. This is the family tree, and women are circles and men are squares. And I like to say that's because men are squares. But here you see each generation kind of going from the grandparental to their siblings to their children, right? So this is how we read these multiple generations. When you come in to see someone like Molly, she takes an extensive family history, and this helps us put together patterns of risk and trying to understand, is there potentially a genetic syndrome? So this hereditary cancer, you see every generation, there's somebody affected. These ages of onset are very young. It's affecting this disease, male and female. So maybe it's colon cancer or pancreatic cancer. And so this is a neon sign for a hereditary susceptibility. The familial cancers is maybe it's not every generation. The ages may not be earlier than you see for just routine, sporadic cancer, but there seems to be more cancer than one would expect. Is that due to some shared environmental exposure? Is that due to a shared genetic vulnerability that is more modest? Is that due to this aggregate of small, tiny genetic influences? And then there you have the sporadic one all the way to the left, which we used to dismiss and say that's just, years on the planet, environmental exposure, hormonal exposure, whatever happens, that's why that person got breast cancer. But in this group, now we really recognize that more and more, even if the rest of the family history is quiet, there is a reasonable chance that we can unpack what that vulnerability is. And so we'll talk about that a little bit more, how those how that benchmark for who should have genetic testing just keeps changing. So here's a list of cancers to which there are a substantial underlying genetic susceptibility. So you see on the left is sort of common cancers or cancers that are more frequent that have a very significant hereditary susceptibility. Oops. So when we talk about the BRCA genes, the BRCA genes that people call them, they really should have been named the OVCA genes because the BRCA genes are the underlying cause for up to 40% of all ovarian cancer. So this is an example where you can have no family history, one person with ovarian cancer, one person with pancreatic cancer. There is such a strong underlying potential for hereditary susceptibility that those patients should always be offered genetic testing, as should their family members, first-degree relatives, and otherwise. It changes a little bit. The more common the cancer, the less the relative proportion that is underlying from a hereditary single gene. But the more common the cancer, the more likely we're just going to find somebody because there are just that many more people being tested. On the right-hand side are some more rarer cancers, so you may not even be able to say this or know what these things are. If this is something that is something familiar to you and you have heard of a pheochromocytoma or a paraganglioma because of someone in your family, absolutely that your family members and or you should undergo genetic testing, just like some specific forms of thyroid cancer, very, very high underlying single gene susceptibilities. So we used to say there was cancers that just don't have a genetic susceptibility. But now that you see these asterisks, even the ones that we used to use as sort of the example of not hereditary, now the more that we have the robust ability to, and I don't know why it keeps jumping on me, to have learned from our whole genome, the more we see that there are, in fact, vulnerabilities that are hereditary that can influence them. It's far more likely, and they tend to not be that high-powered single gene that passes from generation to generation. Probably the only ones that don't have any kind of genetic susceptibility at this point are liver and cervical. Cervical is due to HPV or a viral exposure that is for squamous cell cervical cancer, and liver cancer is environmental unless it's pediatric. So here's a classic pedigree of what we call a BRCA1 family. So here you see that the family member here had bilateral breast cancer, early, very, very early ages of onset, and then after that had ovarian cancer, and that her daughter had breast cancer at an early age, and that there are multiple families. This is absolutely BRCA until proven otherwise. As we have learned more and more about these underlying genes, there are other high penetrant genes or high risk genes that can mirror this kind of family history. I'm not going to get deep into the weeds of what the risks are if we find a BRCA mutation. I just want to give you a sense for the relative difference in risk if you don't carry one of these versus carrying one of these. So there have been, for years, people would quote literature that said that the lifetime risk if you had a BRCA mutation was 90%. Indeed, we find that that is not true for most family members, but it is multifold elevated in terms of the breast cancer risk. And as I had mentioned, very, very high risk for ovarian cancer. And in men, there is a significant risk in BRCA2 for an aggressive form of prostate cancer. Both men and women with BRCA are at risk for pancreatic cancer. And this just continues to evolve as we understand what those risks are and how do we define them, and then how do we refine them. So even if you have a BRCA mutation, you may go your entire life without ever getting cancer, and yet there's somebody else with the same mutation who gets breast cancer at the age of 29. So what are those influences? And that's where kind of the modern emphasis is on trying to not only say, have we found a single gene, but what does that single gene mean in the context of the rest of your environment, your genomic, your nutritional, your exposures. A BRCA mutations are found in every corner of the globe. There are thousands of them, and they can affect men and women are carriers exactly the same. It's just that the cancer risk is significantly higher in terms of developing cancer for women over men. Of note, the Eastern European Ashkenazi Jewish population has a very increased risk for being a carrier just due to population bottleneck phenomenon, founder mutation. So that risk is about 1 in 40 in all Jewish people, whereas in the general population, it's about 1 in 200. Once you've had any cancer in your family, though, those numbers change completely. There are additional other cancers, as I mentioned, and so this is also part of that pattern that we look for in families to say it may not just all be breast or may not just be all breast and ovarian cancer. So pancreatic cancer, melanoma, particularly melanoma in the eye, and then an aggressive form of prostate cancer in BRCA1, a less aggressive form of prostate cancer, in BRCA2 and less aggressive in BRCA1, and male breast cancer. So this has sort of evolved what are the single, reasons to undergo testing, which I'll show you that slide in a moment. This pie is now just saying that there are plenty of other genes out there. So 10 years ago, people may have only gotten testing for BRCA1 and 2. And if you were negative, somebody told you, okay, you don't have hereditary breast cancer risk, or you don't have a hereditary pancreatic cancer risk. And now we have 100 plus genes for cancer susceptibility, which may be for one organ type or maybe for multiple different kinds of organs. But when you look at breast cancer, hereditary breast cancer, BRCA1 and 2 are still the main actors. They are the big players. But we have now a dozen genes for breast cancer, half a dozen genes for ovarian cancer, half a dozen genes for prostate cancer. So all of these are kind of helping to frame at least that many for colon cancer susceptibility. So like I said, this sort of unknown wedge keeps getting smaller, but it's still there, and it's still significant. So there's plenty for us to learn. Again, in how do we individualize how we take care of you? So when we bucket this into sort of what is the recommendations for the average risk woman for screening, what is the recommendation for someone who has a moderate risk, and that moderate risk may be because of a genetic change, it may be because of this polygenic change, which we talk about, or it may be just because of things that we call empiric, that we use models to say, how many family members have you had with breast cancer? What was the age that you got your period? Have you had a delayed menopause? Your BMI? Are your breasts very dense post-menopause? All these things factor into your personal risk, individualizing your risk. And that, again, is sort of the way we're trying to package everyone's care based on all of those things integrated together. And then in the very high-risk population, we can start a breast MRI as early as age 25 and adding in an annual mammogram. So alternating them every 6 months, so that you have a shorter interval of imaging, and we're using different ways to image the breast, risk-reducing surgery, risk-reducing medications. These are all things that we talk to patients about depending on where they are in their life journey. So who should have genetic testing? Maybe by the end of this talk, you will realize that probably everyone, but we do still have standardized guidelines, and there are definitely the most important kind of low-hanging fruit. On that left side are these what we call single indicators. If you or someone in your family anyone has had this history, then genetic testing is not only indicated, but it is covered by guidelines and insurance. The right-hand side, and this includes down at the bottom, so people often ask colon polyps. So you may get a colonoscopy, and when you wake up, they say, oh, we took a bunch of biopsies, or we've taken some. So having had a biopsy is not the same thing as having this very particular kind of adenoma or kind of polyp. This is the polyp that can predispose and, if left alone, develop cancer. This is why we recommend colonoscopy as a preventive in addition to a screening modality. But people who have had multiple adenomas are at risk for a genetic vulnerability or genetic susceptibility. And then on the right side is just sort of a gamish of cancers that may indeed meet a criteria threshold for a syndrome or for indication for testing. And again, now the access has gotten so much more available in terms of even those who just want this information from their own education and their own refinement of risk, that it can be a cash acquired test. There are multiple results. And is there anybody in the crowd who has a question at this point? Let me just take pause for a second.
I just have a question.
Go ahead.
In the slide before, you said something about first, second, or third degree relatives. Can you just explain briefly what that means?
So remember that family tree, and maybe when we break at the end, and Molly can sketch it out really quickly. So your first degree relatives are your siblings, your children, and your parents. So everybody who has one spoke of connection is your first degree relative. Your second degree relative goes out one from there. So it's your grandparents, your aunts and uncles are your second degree. And then beyond that, it gets more extended. The farther away somebody gets from you, the less likely that there is a transmitted single gene risk to you as an individual. So genetic testing is straightforward in how it's done. And what the reasons why we do it is that not only are we trying to identify those who are at high risk, but equally, if not more often, we are reducing risk and avoiding unnecessary screening to give relief or clarity around that risk, so that if we have a known susceptibility, somebody can be truly negative and off the hook. And if it's there is a defined high risk, then we can really refine their care, and we have outcomes data to say that this keeps them from getting cancer, that this keeps them safe, and that we know what to do. The results, though, you can have a negative result, which is we don't find any genetic change in the sequencing. Whether that means they are negative because there is no hereditary susceptibility, or there was a hereditary susceptibility in another family member and they didn't get it. So this is part of what we sort out. Positive, there is a genetic change which puts that gene vulnerable to not functioning properly, and therefore that person at risk for cancer. Or inconclusive, which is something we call a variant of uncertain significance. And that is mostly not of consequence, but one to which there is that we follow forward to make sure that that doesn't change in terms of what it means for that interpretation and what it means for that patient. So how do we do it? Very simple. It's blood or saliva. Results take about 2 weeks. And as I said, it's covered by almost all insurances, including all managed care, Medi-Cal. Medicare, you might not know, but Medicare has not been in the business of prevention. So Medicare will do genetic testing and covered completely if you have had a personal history of cancer, but does not cover testing if you are unaffected, even if there's a known hereditary susceptibility within the family. So this has been a gap that many of the molecular labs have done a great deal of work to try to close that gap around. Testing out of pocket is generally $250 or less. So that has become really a price point that can be much more accessible for many patients. So I have declared Thanksgiving National Family History Day, and that is also coming up for us as the fall. So, when you come with your gravy or your sweet potatoes, come with a whiteboard and just start drawing your own pedigree. There are pedigree drawing tools, genealogy templates, and this is the opportunity to get information, to have legacy information from our forefathers, from our ancestors, to try to get clarity. There are all kinds of ways for people who are interested in genealogy just to get death certificates on family members, to get all kinds of records that can be from church archives. Like, an amazing amount of information can be garnered. But for those who have had cancer or have had another disease, to take the opportunity to try to get records while they still are available will just go a very long way to providing clarity should you ever need it for yourself or for your family. A moment just on protection against discrimination for genetic information. So there historically, there's a lot of anxiety around the potential for genetic discrimination. Your provider might still mention things like that. And so we really want to take the opportunity to sort of talk about what is the reality. So there has been a fully enacted GINA, the Genetic Information Non-Discrimination Act, which is a decade and a half old now, and it has evolved so that the state protections are often many-fold more protective, particularly in places like California, that protect against health insurance, employment discrimination. There are caveats around that so we talk to all patients, things like they're considered voluntary, like long-term disability or life insurance. There is the potential that if a carrier asked you as part of the actuarial assessment, do you have a genetic susceptibility, or what is your family history, that could change your eligibility or the cost. But many states have protections that supersede that as well, including, interestingly, places like Florida, which I recently learned. Okay, so, when you hear about genetic tests, it gets very confusing. Landscapes get very confusing. There's big push to direct-to-consumer testing. What is the difference between the tests that are being offered in clinic and available to us? What are the differences between tests that are that level of clinical fidelity, but you can still get them as a direct patient access? It's very, very busy space. So a few minutes just on 23andMe's DTC, or direct-to-consumer testing, because for a number of years, there was a barrage of patients who were being found to carry a BRCA1 or 2 mutation via their social activity of doing 23andMe. 23andMe was very determined, as a part of their mission, was to democratize genetic information and bring it to the citizen scientist. And so made a very big push to prove that they could transmit medical information direct to the consumer, to an individual, and give them enough tools to be able to do that outside of a medical context. But the platform only tests for very specific changes. So with BRCA1 and 2, for example, they test for the 3 common Ashkenazi mutations and not any of the 1,000+ other mutations. But people have a misperception that they've had BRCA testing and that they're negative, and that's just not the case in terms of comprehensiveness. It's the same thing for all of the diseases that are now listed in 23andMe, and you can go back and unmask and say, yes, I want to know this genetic health risk information. And when we find it, it has, for the most part, been reproduced. It's what they're not finding that is so important to understand. And I don't think that for most people who are just wondering whether or not they can genetically determine whether they can smell the asparagus in their pee or their tongue curls, to be found to have a susceptibility to late onset Alzheimer's disease or BRCA, that's the platform to which that information should be transmitted. Okay, well, what do we want to do about it, though? Because here's a shocking statistic that 90% of people who carry a hereditary susceptibility to cancer don't know. So this is our charge, and this is what kept me up at night, and this is how we said, how do we change? How do we reduce the barriers? How do we find people who are at risk before they get cancer, and be able to do prevention and high-risk screening and surveillance for the earliest detection, and change their clinical family history? So much of this has happened because the technology has become incredibly high fidelity and greatly reduced in cost. So now what used to take weeks and weeks and weeks in cost, on the order of thousands of dollars to do just 1 or 2 genes, we now can readily do hundreds of genes, and to a direct, a patient, if it's not covered by insurance, may have a maximum cost of about $250. Whole genome sequencings are now $1,000. And this was, there's a Moore's Law slide that the first whole genome sequence was $100 million, and that was in 2001. And so now we're looking at less than $1,000. So that crossover between the informatics change and the ability to access information has really allowed us for an opportunity to be able to come forward and say, how do we do this in the best way? So when I started, at St. John's, said, okay, let's just start doing a screener. And when you can see, we had a paper screener for patients who would come into mammography, patients who were coming into our prostate clinic, saying, okay, if there's one yes, all they have to do is circle one yes. And that means they meet national guidelines for genetic testing, and they should be referred. And then we gave a little script to the mammotechs, and we kind of gave a little educational like information, and that's what would happen. Hey, you screened, looks like you might be at risk. Stop by, make an appointment on your way out. You literally like could not pass the door without stopping by to make an appointment. So let's just throw it out there. What percentage of women coming in for routine mammogram do you think met national guidelines for genetic testing? Just give me a percent. I can't hear anybody.
I said 15.
Okay, 15%, so good guess. So it turns out it's 30%, 1 in 3. 1 in 3 women coming in, regardless of kind of their indication, they're just coming for their routine mammograms, meet guidelines criteria. This is a huge unmet need. So of that 30%, how many, when we looked at over 10,000 of these screeners, how many came in for an appointment? How many did we see? Any guesses?
1,000.
Percentage. Give me a percent.
10%.
1.5%. So was not working. The paper screener, let me give you a little pitch, tell you what this is. We were losing all of these patients who are at risk. And this 30%, even though we did this, going on 8 years ago now, the number has stayed remarkably consistent. We just needed a new model. So this is where chat, using AI, using technology, diminishing barriers, figuring out educational tools that met people where they were when they were there, change this landscape. So we implemented something called CARE, which is it was a chat bot, and it's on your phone or on an email interactive questionnaire, which immediately calculates whether or not you meet the national guidelines for genetic testing, and also calculates your individual breast cancer risk over your lifetime based on the factors that you put in. Age, when you get your first period, when you went into menopause, how many children you've had, whether there's family history, et cetera. So we have now, through this, not only at St. John's, but across all of the hospitals or ministries in LA and Orange County, implemented this process. Every woman who's being scheduled for a mammogram, the week of their mammogram, gets this prompt on their phone. They get a text, hey, fill out this quick survey. And then it's flagged when they come in. Now we have an compressed education tool that goes through all the elements of genetic testing, the why, the benefits, the issues around insurance, the issues around cost, all of these things. A patient can elect on that moment when they are getting their mammogram that day to have their genetic testing if they meet this insurance criteria, or convert and say, hey, I'd like to talk to somebody at greater length and try to understand these things. Or if they don't meet criteria and they just say they want to do this anyway, that can also be done on that same day. So from that, we have markedly increased. So now from that 30% who screen positive, now we're seeing 15% of those women are getting tested on the day of, or within a few days follow-up, they get a call back to come get testing. And that testing completion is very, very high, the satisfaction for patients coming through this. And we have found literally hundreds of patients with mutations who carry high risk or moderate risk susceptibilities to any number, not just breast cancer, breast, colon, prostate, uterine, any cancer susceptibility that had no idea and would not have been identified probably, or had been told for years to come in for genetic testing and they never did. So what does that happen? And this is like where the Women's Health Institute is so instrumental in terms of being the entry point for women coming in for their care. Here is a patient who through this process for her same-day mammogram was found to carry a BRCA mutation. So she gets referred to our high-risk breast cancer program to get her high-risk surveillance or through genetics, and her mammograms and her MRI scheduled, discussion about preventive medication. She gets sent to the GYN clinic to see our GYN oncologist for just discussion about when is it appropriate if she needs to take out her ovaries. Because we don't have screening that is sufficient for ovarian cancer, that is the preventive intervention other than hormonal contraception. So this is an important thing for women to know as they go through their reproductive lifestyle, to understand that when they're approaching menopause. She has a BRCA2 mutation. She happens to have a family history of pancreatic cancer. She's now eligible for a very unique program we have, which is our pancreatic high-risk program. It's a combination of screening and research to really understand how do we better find patients who are at risk and what do we do for screening for them. There is screening for pancreatic cancer. People feel like it's just a death sentence, but if you catch a stage 1 or stage 2 pancreatic cancer, it is resectable and curable. And this is what we mean. This is our aims to do. We have, through this, gotten very involved in a bunch of novel interventions. So our supportive care services for nutrition, for weight management, for exercise, for stress reduction, for psychological support, all of that is part of this wraparound and what we do in terms of offering that to our patients. And then all of her family members. So what we call the cascade. Now her children, her siblings, her parents, we know that they are all at 50% risk because she has this mutation. And so we bring the family in. Now we find out that the father has, not only does he carry the same mutation, but now he undergoes some screening and he has prostate cancer. So through his prostate cancer detection, which is high risk based on being a BRCA, now his decision tree is totally different than if somebody was just finding like an indolent prostate cancer. The recommendations for surgery, clinical trials, medication that he may need. And he goes right into the same thing in terms of our medical oncology, surgical oncology, and radiation. So that's kind of what we have been working on to say, how do we find the people at risk who need it? And how do we then take care of them so that they and their families have the greatest opportunity for prevention and protection? I want to just close with the back end to just talk about the difference between this monogenic and polygenic risk, because the polygenic risk is where we're going to be more nuanced about any one person's risk and how do we how do we take care of you differently, even if you don't carry one of these single genes. So if you look at this bell curve, right, if you're all on the left, this is one of these places where you want to be in the 99th percentile when you're taking the SATs or on your grade for a test. You don't want to be in the 99th percentile when it comes to polygenic risk, because that means you are skewed all the way over here into the highest aggregate of all these tiny changes. How when 100 cards are dealt, if you get all the risk ones, then you may have 3 or 4 or 5 times the risk for any individual cancer or cardiovascular disease or diabetes than somebody who's all the way at the bottom of this risk. So pulling apart those curves is the ability to be able to say, we are looking at you as the N of 1, as an individual. Most people do sit somewhere in the middle. That's the bell curve, and they're just kind of plopped in the middle there. And so it may not be dramatic for a whole lot of people, but for those who are on the top 5 and the top 5 and bottom 5%, it is a very significant change in risk. And here are the diseases to which there's already clinical availability, as well as starting to really put a lot of emphasis on people who carry one of those single genes that we talked about earlier, and now saying on top of your single gene, what is your polygenic risk? So why is it that you're 87 years old with a BRCA mutation and you've never gotten cancer? Well, your polygenic risk is probably way over here and you have all this protection. Or the converse. Why is there somebody who is having so much, they're so much more vulnerable in terms of their ages of onset or the number of cancers? This is just an example of, in fact, an integrated test. In other words, the single gene testing, which was negative, and then the addition of the polygenic risk to say, what is this person's lifetime risk for breast cancer? So it's first calculated based on what their prior breast cancer risk score was, all those elements that we talked about, and then adding the polygenic risk score in to say, what is their lifetime risk? So this patient here on the right, despite not having a single gene change, is over the threshold to which we would say you are at elevated risk and we would like to screen you with high-risk surveillance, mammogram and MRI, and to discuss things like preventive medication. So this is a very important change and a nuance in terms of being able to say, how do we take care of every person individually? So just to sum up, not like we said, not all mutations can be found. There are interpretations that are very important in terms of what does that result mean in the context of you and your family. And it always is not a certainty related to the development of cancer or any other hereditary disease. It is an increase in vulnerability to which we use as a roadmap. So just in closing, I just want to mention, because it's all tied in together and it's another place where we have really leaned in to do things differently and provide innovation. So you may have heard about liquid biopsies for patients who have cancer to see whether the cancers come back, to see whether they're responding from cancer. But there is also a huge amount of work going into liquid biopsy as a screen for detection of cancer. So these are the 5 cancers to which we have routine guidelines, national guidelines for who should be screened. So HPV testing for cervical cancer, right? For the pap smear, mammogram starting at 40. These are all the average risk every day. These are the globals, right? This is what we're saying. Well, that might be the thing that we message to everybody, but what about you as an individual person? Colonoscopy dropped from 50 to 45. And prostate surveillance is kind of a shared decision-making, and smoking, low-dose CT. However, 70% of cancer deaths are in cancers that don't have any routine screening. So this is where we see a huge unmet need. These very aggressive cancers, we don't do anything to screen for them routinely. If you have a hereditary susceptibility, we may have a pathway for things that we offer to you. But in the general population, these are just an unmet need. So there was a huge push to say, is there another way? These liquid biopsies or cell-free DNA tests look for fragments of DNA that are being shed by a tumor instead of by your own body, and is able to detect that difference between your DNA and foreign DNA. So it's the same thing as finding a virus in your blood, as finding cancer in your blood, and then being able to say, do we know where not only is that DNA cancer from a cancer cell, but here's where the cancer looks like it's coming from. And that's what something called methylation, or the change in the DNA's pattern in terms of what's turned on and turned off, that is a signature of a particular kind of cancer. So there's currently one commercially available, we call them MCED tests. There are a lot in development, either for single cancers or for multiple cancers. So this is going to be a whole new era in bringing in, trying to understand how best to use this technology, who is it for, how often do we need to do it, and how do we handle results, both positive and negative, in terms of the context of what a patient needs. But you can see there's a huge range of cancers here. And again, the most aggressive cancers are the ones that dump DNA early into the bloodstream. It doesn't mean that it's metastatic. It just means that the biology of that tumor is such that it's turning over a whole bunch of cells, and those cell fragments have the DNA that's going into the bloodstream. So that was a ton of information. I want to take pause here and open the floor to any questions that anybody has, and really invite you to ask your questions, to reach out to us, to things that you're interested in. That MCED testing, we do offer that clinically. The one company that has it is a company called Grail, and the test is called Gallery. We have 2 arms for offering it. One is through our research study for our patients who have hereditary susceptibility, and the other is for just those who want to access the test with a self-pay, because it is currently not covered by most insurances. So we have lots of information on that as well. And just that's part of the 360 care that we're trying to do for men and women, for all of our patients, to say, how are you at risk, and how do we make sure that, if you don't get cancer.
There was a question on that, Ora, because you did mention that genetic testing is covered by insurance, not Medicare, but then there's some of these that are not. So how do you know what's covered or what's not? Is that going in to see a genetic counselor?
Okay, so we'll look at those, and then Molly, also feel free to chime in here.
She's here.
Maybe Molly, you want to answer the genetic testing frequency and kind of how do you know if you need update?
Sure, yeah, so there was a question in the
Yeah,
chat
that was the other question,
about how often you might need to get an updated test. And the answer is it kind of depends. So there have been and always will be new discoveries in genetics. The biggest advancement in our genetic testing technology was around 2013, 2014. So certainly if you had genetic testing done prior to that, it might have just been BRCA testing, and we definitely recommend an updated test in that situation. If you've had testing more frequently than that, or more recently than that, it's possible you might be a candidate for an updated test. Really, the best way to know would be to talk to a genetic counselor. If you have a strong family history and you had a smaller panel that didn't find anything, there might be a new gene on these larger panels that could be relevant to you, versus if you don't have such a significant family history and you had a panel test a while ago, your genes don't change over time. So unless there's a strong indication for an updated test, it's not always necessary, but really the only way to know for sure is to talk to someone in genetics who can answer that question.
One of the other questions was,
and have your result.
Yeah, we need to see the first result.
How do you know if you got testing through your primary care doctor, how do you know if that's sufficient? Is there a way to know that, or you can call? Or?
Yeah, you can check in with us. We can, if you've already been tested, you're still welcome to come in and meet with a genetic counselor to review the results and see if some of these tests that Dr. Gordon talked about, like the polygenic risk score testing, might be appropriate for you. And, if it was done just a couple of years ago, doesn't mean that there's not an opportunity for some updated test. Best way to know would be to talk to a genetic counselor.
Good. Any questions from you guys? No. There was another one that came in. So you talked about both spit and blood. And is there a difference in that?
So generally speaking, they're essentially the same test. We often order our genetic testing on blood because it can be accompanied with RNA analysis, which was one of the recent updates in genetic testing technology in the last 5 years or so. It increases the sensitivity of testing by a very small amount. So we still also do genetic testing by saliva. A lot of people have concerns that if they do it with saliva, it's not going to be as accurate, and that's not really the case.
Okay.
But there is a very minor difference between the two. So if you come in and see us, we would do it with a blood test most of the time.
Excellent. Are there any cancer risks you don't want to know about because there's not a lot you can do for it? It's a great question.
It's a really good question for a genetic counselor. That's the conversations that we really have. I mean, that really used to be pancreatic cancer was the one that most people would bring up as that exact example if they had it in their family history. Years ago, we didn't have the options that we have available now. And so people would say, I really don't want to know if I'm at risk to get that kind of cancer. And now, I used to say to my patients a few years ago, 10, 15 years from now, we'll have a blood test that can screen for pancreatic cancer. And that day is now today, right? So that's kind of the way that we think about it. We will know this information about you. And as our technology gets better, our screening will get better. It is true that there's always a possibility when you do this type of test that we might find out about something that we don't have a guideline for. And that's what we talk about in preparing for having the test and getting the results back.
And it is getting the information from a genetic counselor as opposed to some other place where you don't have that warm hand to be like, okay.
And just answer the question and make it clear that, the vast majority of the information that we get from this testing is actionable. That's the way it's designed. It's meant to find information that we can use to that patient's benefit. But of course, any kind of genetic testing, there's always the possibility for something that might be a little anxiety provoking.
Right. And then to separate, because it's also confusing with kind of genetic testing. So if you have had a personal history of cancer, you may have had genetic testing on your tumor to help decide about treatment. And that often gets very confusing. People think, well, I had genetic testing when I had my colon cancer or my breast cancer, but that's not the same thing as risk genetic testing or the susceptibility, the what we call the germline genetic testing. And then this last test that I was talking about, the liquid biopsy, uses DNA, but it's tumor DNA that's circulating. And so that is a moment in time. That is not anything to say risk for the future or whether in 6 months there might be cancer. It is saying right now, do we find cancer cells floating around in your blood, fragments of cancer cells? And that's the difference between those three different tests. So a germline genetic testing, so the BRCA and the hereditary testing, mostly you'd say, you do that once, but we say you do it to bring up to whatever. So we want you to do it once to 2024 standards, and then you're kind of done. And then you check in every couple of years. Is there anything new if we didn't find anything? The testing like the liquid biopsy or the MSED testing, maybe every year or every other year as a screening, as an addition to cancer screening. And the polygenic risk, which is that in between, that is just transforming pretty quickly. So those tests have been updating every couple of years because we just find more and more of these tiny variants and have a better nuance in terms of that risk. But the same thing, your DNA, your germline DNA doesn't change.
Great, and I think there's a question here.
Mm-hmm.
So are there standard genetic tests that are now given to women who are planning to have a baby or, going in for?
Yeah, so outside of the cancer sphere, the main thing that you might be thinking of would be for planning to have a baby would be carrier screening. So we can test for recessive diseases that person would never know they were a carrier of until they had a baby. And if they do carry something, then their partner would want to be tested for the same thing. And then when someone is pregnant, there's genetic testing that can be done. The big test that's often done nowadays is called NIPT. It's a blood test that screens for chromosome abnormalities in the baby. It actually uses a similar technology to the tumor testing, the Gallery test that Dr. Gordon was talking about. So those are the two main areas of genetic testing that's done in that kind of population.
And then there's genetic testing for cardiovascular disease. So for genetic susceptibility to problems with your heart muscles, problems with the conduction, so arrhythmias, all of those are also have significant underlying genetic susceptibility. So if that's in your family, we have genetic testing to address all of those things too.
Great, and then there's another question there in the chat.
Yeah, a question about reclassification of genetic variants, and I hope I'm understanding this question correctly, that a lot of times we will get these results that Dr. Gordon mentioned. You can get a positive result, you can get a negative result, or you can get something called a variant of uncertain significance. It's quite common. We all have a lot of mutations in our DNA, and so sometimes the laboratory picks up something that we need to do additional research about to know for sure what it means. All of that research is done by the laboratory, so we don't really necessarily have a hand in that. Sometimes we'll have a patient situation where we submit that family information to the laboratory to try and encourage them to say this does cause cancer or this doesn't. But generally speaking, when we get results with that kind of variant identified where we have uncertainty, we treat it like a negative result. That's typically what is the case, just because, again, we all have so many mutations in our DNA. Most of it is just benign genetic variation. And we do get updated reports from the laboratories regarding the understanding of these. And so as time goes on in the future, if it turns out they identify a risk of cancer is associated for a variant that a patient of ours carries, we would get an updated report and we contact our patients in that situation.
And then another question. So, Ora, you have renamed Thanksgiving what? National Family
History Day.
Which I actually think is brilliant to do that. But the question is, if you see patterns and you have children, grandchildren, how do you handle when you bring that up?
Another good question for a genetic counselor.
Well, this is what you do, Molly.
It's a long conversation.
It is, but just, as people are thinking about it, like, when do you actually have those conversations, or do you talk to someone like you and you would walk them through that?
Yeah, of course. We're always available for our patients. A lot of times the thing that we offer for someone who tests positive is a family letter. So you might not have the language to explain this, even like from a scientific perspective,
Right.
let alone emotionally. And so we have these letters that we write to say, dear family member, I'm writing to let you know about this information. We provide our contact information so that family member can reach out. And we have a lot of conversations with people about, of course, there's a natural feeling of guilt about passing things on to your family, but we want to reframe it as you're providing them with this information now, especially when you're passing it on to your younger children. If they're young and healthy, they now have this information for their lifetime to use to their benefit. So there's a lot of different ways to frame it, but it can be a difficult conversation for sure.
So we're just about over time, unless somebody has a question, but I do want to say that in addition to Molly, there are several genetic counselors under Dr. Gordon that are available. Sometimes your primary care doctor might be able to walk you through that depending on what their comfort level is. But I think it's a great resource to know about that's out there because a lot of people have questions. And if somebody were to see you as a genetic counselor, is that covered by insurance or only if they meet certain criteria?
Generally, the genetic counseling portion
Yes.
is covered by
Okay.
insurance. The testing is, dependent on what Dr. Gordon talked about, whether you meet that kind of family history criteria. But the out-of-pocket cost for testing is
Are
fairly
so much
low at
better
a couple
compared to
$100.
a decade
People
ago.
expect it's going to be $5,000, and it's not quite as expensive as people think it's going to be. So it's more accessible.
Okay. Any last questions? I see some great comments. Thank you all for being here. We will be doing these every month. We're going to try to come up with a schedule of our upcoming talks, and we appreciate you guys being here, especially Molly and Dr. Gordon. I know it's late in the day, and we appreciate you guys being here.
I think this is just so wonderful, and thank you so much for doing this for our patients and for just giving every different way for people to get informed and to help, know their risk and what to do and take care of themselves. So happy to come back at any point and talk about it. Women's health touches every aspect of genetics is touched by, for women's health and for prevention. So we love it. Just one note that if you have a personal history of cancer and you were treated at St. John's or at a Providence facility, we have a walk-in clinic too. So again, kind of everything to break down barriers to care. You can come to the cancer center, see that same video that we have for so men or women, the same video we have for our mammogram, and get genetic testing on demand. And then the follow-up and the interpretation is all individualized.
All good information.
Great, yeah.
All right.
Okay.
Thank you,
And
guys.
then we're going to start doing care in the women's
Correct. We're going to start doing the genetic testing here. That's that care program.
Exactly the same thing. You get screened and then you have the opportunity to get same day testing.
Excellent. All right. Thank you, guys. Have a great night.